surgery. What we haven't been able to improve on over the years, however, is how we can make that rotator cuff heal, and that is absolutely the rate-limiting factor of rehabilitation, and also currently a very focused area of orthopedic research as to what it is that we can do to make the rotator cuff heal better and faster.
So what's important is after you repair the rotator cuff, depending also on the side, is what you do afterwards.
Correct.
Because you can't cheat biology.
You cannot cheat biology.
Exactly. You're going to take a certain amount of time for that tendon to heal down to the bone. So it's very important to abide by the physical therapy and the instructions given by the orthopedic surgeon afterwards in order to give that best potential for the tendon to heal.
Absolutely. And that sometimes is some of the less desirable parts is not so much the surgery as that afterwards requires a period of prolonged immobilization, because we know from animal studies that if you do an animal rotator cuff repair and then you move that shoulder around a lot, the repair fails at a higher rate, and that's thought to be because we're not actually sewing tendons back together. We're taking a tendon and trying to get it healed down on the bone, and if by moving the shoulder we create motion at that repair site, that can interrupt healing and lead to early and excessive failure.
Well, thank you very much. That was a very good overview of the rotator cuff, the injuries that occur with the rotator cuff, and what we do to repair it. Stay tuned. We still have much to talk about the shoulder, and in the more younger, athletic individual, what type of injuries can occur. We'll be right back. Welcome back to Healthcare from the Hill. We just discussed shoulder injuries, rotator cuff tears with Dr. Aaron Schachter. We're going to move on to the younger or more athletic type of injuries in the shoulder with instability. It's a different type of injury than the rotator cuff. And as Dr. Schachter said, if you can consider the shoulder a ball in the cup like a golf ball on the tee, the golf ball can fall off the tee very easily unless there's something else to hold it there. What's there to hold it? The ligaments, the tendons, and the muscles that keeps that ball in the socket, providing the shoulder an extreme range of motion and the ability to do multiple things with flexibility and a return to full activity and full mobilization. If we can go to the next slide, we'll show a little bit about instability and shoulder injuries. In the thrower, there's actually phases of throwing. This is the athlete. In each phase of throwing, different injuries can occur, and it is important to find out where is the pain, what position is the shoulder when you do have the pain, and also what is your range of motion of the shoulder on your throwing side compared to the non-dominant or opposite side. Next slide. Again, if you're looking at the shoulder, this is staring directly in your socket. The ball has been removed. The socket looks like essentially a pear in the middle. It's a small, shallow socket. That's the bony architecture. But all around it, you can see there's a lot of other structures. Those are the ligaments and the tendons surrounding the shoulder. Even your biceps tendon, the long tendon that comes from your biceps muscle, goes all the way into your shoulder and is found actually in your joint. The capsule around the shoulder has different thickenings, which is protective and allows you to get more stability of the shoulder based on these thickenings. These are very important, and those are the part of the capsule that is actually repaired when an injury occurs. There is also a labrum around the socket, which provides a little deeper portion to the socket, and we'll show in a little bit different slides. Again, that's soft tissue around the bony architecture to provide you that stability. Next slide, please. So again, if you're looking at the glenoid or the socket, which is in the center of the screen, all around it is the labrum. To the labrum, the joint capsule then attaches, but this is a thickening which provides almost like a cushion around the socket, deepening the socket without any bone. Now, if this soft tissue starts to tear off the socket, that golf ball will fall off the tee, and the humeral head or the ball can shift away from the socket, again causing different biomechanics of the shoulder and thereby pain and instability. Here in this slide, it is the biceps tendon, which is inserting right on top of the glenoid or the socket, and it's starting to elevate off the socket, which can obviously cause pain, especially in the thrower. Next slide, please. This is an arthroscopic visualization of the shoulder where the cannula is shown in the upper right hand of the screen, and there's a probe, metallic instrument, showing that the biceps, which is the white tendon all the way on top, is starting to lift off the socket, which is just at the bottom. The ball is very much to the right side of the screen. And in the thrower, as you call a peel back mechanism, that biceps tendon can actually start tearing off the socket and over time can provide significant amount of pain and also difference in the throwing mechanics. Next slide. This is a labrum, which is towards the front part of the socket. Again, you're staring directly at the socket. The ball is down to the left lower side of the screen. This tissue deepens the socket. Once it starts to tear off or fall off the socket from a dislocation, the ball can now shift further away, again changing the biomechanics of the shoulder. Next slide. So what do we do about it? We have to take the tissue and repair it back to the socket. Here we see the ball on the upper left side of the screen. The socket is actually at the bottom side of the screen. And the labrum, which is indicated here, has to get reattached to the socket. We use different type of instrumentation and anchors with sutures and stitches to help do that. Next slide. Finally here, looking at the socket at the bottom part here, these are stitches where you can see the soft tissue or the labrum is actually taken, reattached to the socket with stitches. Here again, we have to wait until the soft tissue attaches back to the socket, and these stitches hold it in position until it heals fully. Let's go back to Dr. Schachter. So instability is, again, a different type of injury than rotator cuff tear. And you generally see it in the more younger individual, especially with traumatic type of injuries or repetitive, especially overhead type of injuries. Now, because you've actually worked with professional athletes, if we kind of go to the labrum and impingement or what you stated originally about different type of rotator cuff, even injuries in the throwing, can you expand a little bit on that?
Right, so the throwing shoulder has a very specific set of conditions or pathology that can evolve that we've known about specifically what that is for about the past 25 years because that corresponds with the advent of arthroscopy. So we know that the motion of throwing overhand, particularly for a pitcher, requires the shoulder to go in very non-anatomic or places it wasn't designed to go to create the torque. And we know that that excessive torque can begin to cause pathology in the shoulder, particularly at the top part of the labrum, which is superior, and it has given rise to what we coin a slap tear or superior labrum anterior to posterior, front to back. Now there's some thought that as that occurs, one of the more common symptoms would be a pitcher saying he has a dead arm i.e. he has lost stamina, he has lost velocity, control, potentially all of the above. If gone unchecked long enough, there is some theory that that causes a very small amount of instability, not a dislocation instability, but a very small amount of what we would call micro instability, that while it doesn't feel like your shoulder is dislocating, it places excessive tension on some of the other structures around the shoulder, and that's what is thought to potentially give rise to the failure of the rotator cuff in the throwing shoulder.
So generally for that, it's internal impingement that can
Correct.
occur, and it's more towards sort of the back part of the shoulder with specific positioning of the shoulder,
Correct.
especially for throwing.
Correct.
Now, I know when I see the patients in the office, in a thrower, the amount of external rotation or the amount of motion you could do in this position further back, a pitcher actually has that motion, can even go all the way till the arm is flat around the back.
Very much like your illustration. What's also important to consider is not just how far they can go in one direction, but how far they can go in all directions, or the concept of the total arc of motion. Because oftentimes throwers, especially young throwers, their bodies will accommodate over time so that while they can gain external rotation to literally get their hand flat to the floor, much like your illustration, they will lose internal rotation. So we need, which is the ability to go down. So when examining a pitcher, you need to make sure, A, what their total arc of motion is, and B, how does that compare to their uninvolved shoulder? Because oftentimes, if they're similar, we would consider that a normal accommodation. The times when pitchers can run into trouble is when they lose more and more and more of their internal rotation, so that while they are able to externally rotate their arm an excessive amount, their total arc of motion is much less than the uninvolved side.
And that's more of what we see, the subtle instability, which is more associated with pain.
Correct.
Now, you also can get dislocation, which is a different type of labrum injuries where the shoulder or the ball actually dislocates and shifts completely from the socket,
Right.
usually to the front.
Right, not so subtle instability. So there's traumatic dislocations, meaning you fell down and you dislocated your shoulder and it came out and you need to go to the emergency room. And then there's also atraumatic instability, which sometimes can happen just because someone has a looser shoulder than the next, or in certain overuse sports, especially swimming, where they usually don't completely dislocate, but the patient has the sensation that their shoulder ball is kind of perched on the socket.
So that's more of a multi-directional instability.
We would call that multidirectional instability. And it's important to discriminate between the two, because the traditional thinking, which still holds true, is that recurrent traumatic instability we should fix because there's something deficient, there's something in the shoulder that's not where it's supposed to be, leading to the increased risk of recurrent instability, as compared to the atraumatic instability, which we like to treat with physical therapy to strengthen some of those dynamic stabilizers around the shoulder. Because if you take someone who's a swimmer and you make their shoulder tight, it's either going to be tight and they're going to have trouble swimming, they're not going to be very happy with you, or because we know those tissues are looser, there's a higher rate of failure. So we like to keep them out of the operating room as long as possible, given those risks.
So then they have to use their dynamic stabilizer or the muscles and tendon to try to compensate
Correct.
for the laxity they have, because the shoulder essentially, again, is a very mobile type of joint.
Very mobile joint. Correct.
Now, in the traumatic dislocation where the ball actually pops out of the shoulder, age also has to play an important part of that.
Absolutely. So we get back to the rotator cuff, because we know as we get older, the rotator cuff kind of weakens from the inside first. So in a 16-year-old, 17-year-old who dislocates their shoulder, the rotator cuff is very robust. And almost 100% of the time, upwards of 90% of the time, they sustain a tear of the anterior labrum, which is again the anchor point for some of the ligaments, or really capsular thickenings of the front of the shoulder. Now when that comes off of the socket, it typically will kind of heal on the socket in a non-anatomic place, which leaves the front of the shoulder, the front of the socket, unstable, increasing risk for further instability. And we know that especially young men, less than 20, who have sustained a traumatic shoulder dislocation, their risk of sustaining another one in their lifetime is upwards of 90%. Now, as we get older, the weak link in the chain becomes the rotator cuff, so that especially, not older, but upwards of age 40, we know that the risk of sustaining a rotator cuff injury is much greater than when we're 20, and we need to remember that when we're evaluating the patient, because we would treat a traumatic rotator cuff tear in a 42-year-old who dislocated his shoulder much different than we would a traumatic rotator cuff tear in somebody in their 70s or 80s.
So if somebody that, let's